Okay.
Okay, so this is a lecture that's about boundaries and frame. We got a little bit started with some of the material last week, um, and also how it applies in enmeshed communities, enmeshed ethnic communities, which have kind of different boundaries culturally than secular cosmopolitan communities, which is the context that psychotherapy was developed in. So some of the standards for psychotherapy in terms of boundaries are culturally off. And as psychotherapy has become more culturally sensitive and diverse, we need to adapt our thinking for communities where boundaries are different, and many other cultural practices are different. Um, because I work in Orthodox Jewish communities, including Hasidic communities, and many of you do, that's the example I'll be using of ethnic communities. Um, but this is not, it's really just an example. And I'll ask Alejandra, who herself is an immigrant and also is part of an ethnic community and also part of other diverse communities that are, I think, small and somewhat enmeshed. I'll ask you to chime in and give us examples of things that apply to the communities that you serve and work in. You
Sure.
have a clinic that serves like a very specific community, right? Like you supervise in a clinic that serves LGBTQ people, and that's a very small, tightly knit community as well, in the Midwest especially. So I'll ask you to chime in with cultural examples for you, and I'll explain the cultural examples that many of us are familiar with. Try not to use terminology that's too esoteric. So, an overview as to what we'll discuss today. Um, we're going to discuss professionalism, professional behavior, unprofessional behavior.
All right. Menachem's in the waiting room.
Okay. Fiduciary duty, dual relationships. Those are all aspects of professionalism. Boundaries, the frame, ethics versus clinical technique. Often boundaries are described in the context of ethics, and we'll talk a little bit about ethics, but I'm really talking about boundaries as a clinical technique that helps you as a therapist, not in terms of ethics. And that's really I would say, the main um, innovative aspect of this approach is that this is to see boundaries is something that really is a technique that helps you function as a therapist much better than you would if you don't have attention to your boundaries. That's really how I want to see it. It's not looking at ethical breaches. It's looking at clinical competency and how your boundaries can be used to really serve your clinical skills. Small world issues, but we're not looking at spelling issues today, just small world issues. And small world issues means when you work in a very small community, you come into contact with your clients in other settings. You know people that they know. We're going to talk about that. Dealing with helpful others. Anyone know what I mean by helpful others? I mean, Rabbanim, that's rabbis. Askanim, Alejandro, Askanim are community organizers. Community organizers. Rebbitzins, those are the wives of rabbis or female communal leaders. And CJMHYs, do you know what a CJMHY is?
No.
It's a certified Jewish mental health yenta. Okay. Which is a topic that I learned from a colleague. A yenta, Alejandra, is a gossip. That's what a yenta means, a gossip. But oddly, the word yenta is also a name that many people have. So it's like a very funny name to give your child. There are people named Yenta. It's a very
Talk
funny.
about small world issues, Dr. Klafter.
What'd you say?
Talk about small world issues.
Right, exactly. So there are just people in now. This is, I'm sure it's true in all small ethnic communities. These are just the communal leaders. The general term for this is culture brokers. I don't know if anyone's ever heard the term a culture broker. It's people that in a given culture community have a lot of authority and status, and they kind of determine the cultural norms of the community. These are the culture brokers of Orthodox Jewish communities. And so often they're making referrals to us, they're monitoring whether we're making progress in therapy, they're sometimes arranging for payment by third parties. So they have a lot of power, and you can't really ignore them in the therapeutic process. So I'm going to talk about that a little bit today also. So I want to talk about professionalism and fiduciary duty. So what does it mean to be a professional? This is how I would define it. Professionals provide services to their patients or clients, and I can expand this beyond psychotherapy, and expect nothing in return other than the fee for their professional services. This is totally different and distinct from friends, lovers, a rabbi congregant relationship, a teacher student relationship, neighbors, a parent child relationship, siblings. This is a totally different kind of relationship. In therapy, which is one example of a professional relationship, there's an even larger power differential. There's some power differential in all professional relationships, but there's a great power differential in therapy. And that's because the patient is called upon to be really vulnerable and needs the therapist to maintain safety and protection in the relationship. So that puts the therapist in a really strong position of power. There are other relationships that have power differentials as well, but I'm focusing on therapy, and I think it's a unique, pretty extreme power differential in a professional relationship. It's easy to exploit this differential in power. Really, that's true of all power differentials. It's easy to exploit someone who's on the lower side of a power differential. Therapists often do not recognize the profound vulnerability of this relationship. And I want to say that, I'm not saying that like I recognize it and you guys don't or something like that. Like I also have trouble in the moment recognizing just how vulnerable patients may feel to me at any moment. It's something to really keep in mind as a therapist. You have to really focus on it. It's not intuitive to understand this in the moment. We're focusing on a number of things, technically listening to the session and focusing on how vulnerable the patient is has to become one of the things that we're focusing on in these relationships. The patient will ultimately be exploited in friendships, business partnerships, or taking on the therapist as a client. Like if you have a patient who's an accountant and you would hire them to do your accounting services, ultimately that patient will be exploited by you. And why is that? It's because when someone is so vulnerable, they can't really advocate for themselves normally. Think of all the things that you need to do to advocate for yourself, to get paid, to explain why people have to come on time. If you had like a lot of vulnerability to the person that you're trying to negotiate with, you'll be much worse off in your negotiating position. So if you would have your client provide you professional services like as barter or something like that, ultimately they're going to be exploited. They can't really be as professional or self-advocating as they normally would be because of their vulnerability to you. So what is unethical? What does it mean if something is unethical? If something is unethical, it means that there's a rule or a professional consensus that engaging in this type of behavior with your client is going to exploit them, or is likely to exploit them. It's not just your personal sense of whether you think you're exploiting your client. It's really, there's a professional consensus in your professional organization, in your state licensing board, in a group you belong to. And different groups have sort of different ethics. If you belong to the National Association of Social Workers, they have an ethical code that I'm sure you agree to follow when you join. We have one in the American Psychoanalytic Association. So these are like official guidelines and principles and rules that the profession has agreed upon. It's not your decision whether something is unethical. It's not your judgment whether it's unethical. It's like codified and formalized by organizations. Boundaries outside of therapy. I want to talk about what boundaries are outside of the therapy scenario, because number one, it makes it easier to understand it in therapy. And number two, it'll help highlight how complicated boundaries become when you're in a small enmeshed community where you have other connections to patients. So I'm going to give examples of people who I would say challenge your boundaries socially. So we're not talking about your clients. We're talking about just as people who come over to your home without calling first. There are some people who you have the relationship with them that they could just stop by and say hello because they happen to be free and they happen to be nearby. Those would be like very close friends. Very close friends are, welcome to come over to your home. People who you don't have that relationship with and they would stop by your home, you feel really differently about it, right? And this is maybe an idiosyncrasy of the Jewish community, that because on the Sabbath, we don't use the phone, we don't text one another, and we're not doing anything and we're not driving. So people are out walking. People go for walks. They walk to synagogue. They walk to other people's homes. Their kids are on play dates, so they walk their kids on play dates. So you're out walking. A lot of people will just sort of drop by their friends' homes that they know are also doing nothing, probably on the Sabbath in particular. So that's like a time that it's really common that people will just stop over your home. So if someone stops over that has that relationship with you, you're like, oh, it's like such a nice surprise that they came over. If someone doesn't have that relationship with you, but you would like to have that relationship with them, that's like a boundary crossing. They're like kind of taking the friendship a little bit deeper, and you'll feel happy that they came over. It's like a gesture they made and they're deepening their friendship with you. If it's someone that you don't want to have that kind of relationship with, or someone you have tension with, or someone that seems to be always trying to get inside your social circle in a way that you don't really want them there, you will feel a little bit invaded that they came over your house without announcing. That's a boundary issue. We don't use that terminology usually, but that's what you're noticing. You're noticing that this person is kind of taking a step that you didn't really want them to, and it makes you feel a little awkward. Your guest opens your refrigerator without asking you, or looks through your things without asking permission. That's like, feels like a little bit of an invasion. That's a boundary issue. You'll be sensitive to that because they're crossing your boundaries. Now, your boundaries are not spelled out. Your boundaries are in your mind, and it's really based on feeling and comfort. You haven't like written down a bunch of rules, but if you notice someone does that, like they just open your refrigerator and do that. I have a client in therapy who recently was on a date, and he didn't really know this young woman very well yet. And he noticed that she went ahead and adjusted the air conditioning in his car and changed the radio station to put on music that she liked. And then I think she hooked up her Spotify to his car to share a song with him that she thought he'd like. And he really liked it. He really liked it. And he was wondering in therapy, like, why did I mean, other people do that and I don't like it. I really like that she did. I said, it's because you like her. And the fact that she took this step to be closer to you, like you enjoy that. That's like, it's a sign that you're interested and that you like her. Like you like the fact that so you can use your reaction to someone overstepping the boundaries to kind of monitor, do you enjoy this? invading your personal space or physical touch. I don't know if any of you were Seinfeld fans, but there's like a Seinfeld episode that's called The Close Talker. It's like someone who stands too close to you when they're talking. So that's what they were talking about on the show. It's like, that's my personal space. Or someone touches you when you didn't ask them to touch you, and you feel off put. Again, if it's someone you really like and you want to deepen your relationship, you won't mind that they touched you. Suddenly the conversation veers into personal subjects that you're not comfortable discussing, versus when you're happy that someone did this, you're making a new friend. Someone says, can I tell you about this experience I had today with Alejandra? I just need to run this by you. So I'm gossiping about Alejandra with you. If you don't want to feel close to me, you'll be like, you won't want to do that. If you like the idea of having a closer friendship with me, you'll enjoy that I'm gossiping with you, or if I overshare something about myself, I'm oversharing if that's not the kind of relationship you want to have with me. If you actually like the fact that I would consider you a confidant and you would do the same toward me, then the relationship deepens. These gestures sort of determine, and your response to them determine the shape that a relationship takes. You have a friend who wants to borrow money. That makes most people feel uncomfortable. It's like, I like being your friend. I don't like being your creditor. And it's hard to say no when a friend wants to borrow money. And it would be hard to collect if your friend defaults on the loan. Someone overstays their welcome after a Shabbos meal. So Shabbos meal, is, again, it's very common that we socialize on the Sabbath. And at a certain point after a meal, it's like, okay, we ate the food, we talked for a while. Some people actually sing songs on the Sabbath. They serve dessert. We said the prayer after the meals. We're still talking. At a certain point, it's like really time to leave. Like people start looking at their watch. People are tired. People often want to take a nap on the Sabbath, or they have to walk their kids somewhere. And some people, like, they kind of don't get the message. Like, you have to ask them to leave. That's a boundary issue. They don't see, like, there's a limit to how long I should stay in your house. People give you personal advice without being asked. That's culturally normative in some communities, unfortunately. But that would be someone overstepping your boundaries. And if you're annoyed, it's like, I didn't really ask. I don't really want to hear that from you. I think the general principle here is people are acting closer to you than you wish they would. Now, just some of the
Klafter, in regards to professional, clinical, what's your approach in regards to handshake?
Well, let me move forward, and I think we'll get to that. It'll be easier to talk about that later. And I think handshakes are a totally culturally determined thing. I think communities where handshakes are normal, rejecting a handshake is going to be sort of awkward. In some communities, men and women never shake hands. That would be inappropriate for a man and a woman to shake hands. So it's going to be, so I think you have to really look at the cultural context. It's not really a clinical issue only. It's really a cultural issue. And, your practice exists in a community with a culture. So these are things that just really are determined by the culture. So in our community, in Hasidic communities, for example, actually Hasidic communities a little bit less than other Orthodox communities. Other Orthodox communities, it's very common that we eat and sleep in other people's homes. That is very, very common. It's actually, interestingly, less common in some Hasidic communities. Men and boys are naked with one another daily at the mikvah. The mikvah is a ritual bath, like the ritual bathhouse. And there is a religious custom that men immerse in a ritual bath every morning before prayers. So you see lots and lots of people naked every morning. You may be in the bath with them every single morning. That's like culturally normal in this community. People tend to have lots of children in this community. And the way people get married is that children are set up to meet one another on, culturally sanctioned dates. And we learn a lot of information about the other family and about that prospective match before they go on a date. So people are constantly looking at other people's families and thinking about whether, would they be a good match for so-and-so for marriage? Do they have someone in their family that would be a good match for me for marriage? I heard that they have a son who's looking to get married now. What do I know about them? What can I, like, this is constantly going on in these communities. So we're looking at other families very closely because, their children are potential matches for our children or other people that we know. We see each other every single day, school, synagogue, events, celebrations. We live in these very small, tightly knit neighborhoods. There are some neighborhoods where there could be a building with, 24 Hasidic families in the building, and they see each other day in, day out on the stairs, in the elevator, coming in and out after shopping. I mean, we're living on top of one another all the time. We scrutinize each other's clothing. Dressing in a certain style is considered sort of like a religious uniform. And when people deviate from the uniform or become very stylish or take on a new style, everyone notices. It's culturally interesting just how much attention is devoted to clothing in certain religious communities. We pray together, shop together, do business, lend money to each other. I mean, that's what goes on in these communities. We give each other meals when children are born, when relatives pass away. It may be similar to other ethnic communities. I'm curious to hear from Alejandra about the communities that she's familiar with. But the main thing is it is not the norm that was assumed when ethics and rules were drafted and formulated for psychotherapy. Those rules were developed by secular, cosmopolitan people that lived in large cities, and it was very easy to have a full practice of people that you have no social connection to whatsoever. So you're like an anonymous person that doesn't have any other connection with your patients. And it's just not realistic if you practice in an ethnic community or a small town or village. It's not realistic. And it's not that people in small ethnic communities don't have the same sensitivity to ethics. It's that that's not what our social lives look like. So these rules it's not that they have to be changed. They have to be like adapted and understood as principles. And the application is different when you have so many connections with people that are your clients. Alejandra, is there anything like in your communities? And I don't know if since you've moved to Cincinnati, I don't know if you're part of a Colombian community or not. I mean, you're an immigrant, but like anything that's similar or different about your experience.
There's a lot of similarities, but I think it depends. I mean, I moved here when I was 10, so I to California. So it's I kind of share both cultures to some degree. But there are a lot of similarities. I think how you welcome people into your home seems very similar. Definitely, food is very, very important. Gifts are very important in Latin culture. Opening up your house to people. I mean, I remember things like people, but then at the same time, kind of expecting people to also have, boundaries, like it's time to leave. And sometimes I remember things like that as a child. People would come visit and they'd stay for 6-7 hours, and my parents being like, "Oh my God, when are we gonna, get these people out of here?" But you couldn't say that. You couldn't say, it's time to go. That would be the rudest thing in the world. Yeah.
I also feel like, and I think this may be even more so in the last year or so, that I think that immigrants feel a lot in common with one another.
Yes.
And, lately in certain cities with, actions being taken by, ICE, feel solidarity and alienation with one another. And I think that people that are immigrants feel like they're part of a very tightly knit community and feel like an obligation to protect one another and have a lot of fears with one another. I think that's a new thing emerging just in the last year that I see. I have a lot of immigrant patients, and I hear this in common with one another. I think that's like a new sort of culture that's emerging right now. I mean, it already was a culture, but it's changing with what's going on in the country politically, I think. Okay, so you're going to say something else, Alejandra, or that was...
No. That I think you're right. I think that that is happening. Yeah.
So I'll go to the next slide. So one of the most common and maybe important ways to think of boundaries is a rules-based approach. That, there are a number of rules, things that we just do not do in order to preserve the boundaries. So here are like some examples of rules. Well, first I want to say the definition, which we went over last time. Boundaries, the definition is the limits and rules that psychotherapists place on their behavior in order to preserve and protect the professional relationship. To keep my relationship only professional, I have limits and rules I follow to preserve my professional role and not slip out of my professional role. So the rules-based approach would be, no gifts, or at least no valuable gifts. I don't accept gifts from patients. Actually, I'll pause here for a moment. I think gifts are nuanced. There are times that many of us have accepted gifts from patients, and not every gift is very emotionally meaningful necessarily. And sometimes not accepting a gift makes it harder to go on in therapy than accepting a gift. I'm going to talk about that later. But there are times, I have a patient who every year, this is a former patient now, she's an artist, and every year she would create an artistic greeting card and have it professionally printed, like hundreds of them professionally printed. And she would also bake honey cakes and send them out to hundreds of people. And sometimes it would have like a photograph with an update about her family. So if she would bring me, along with hundreds of other people, a greeting card and a honey cake around, like Thanksgiving or Christmas or New Year's time, that isn't really a very significant gift toward me. This is what she does to everybody. I don't consider it to be something that needs a lot of therapeutic attention. I might decline the gift because I have a rule that I don't accept gifts, which serves my practice, as we'll talk about later. But it isn't really the same thing as someone after a really contentious session where they yelled at you and then they feel guilty that they yelled at you, that they come and give you a gift, or they want to smooth over that they were mad at you. Those are two very different things. So whether you accept a gift or talk about the gift, it really depends on the clinical context.
I think if I could interrupt you for a second, I worked at an agency in East Harlem, and where there was a very large Latino community, and there was the therapist that one of the therapists that was working at the agency was working with somebody with a couple who was a Latino couple, very poor Latin couple, and they went and bought the therapist a very expensive purse. Very, very like leather, blah, 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 and that was it
was a big sacrifice for them.
It was a really big sacrifice, and it was also, very important that she accepted, but she didn't understand that. She didn't get that. She just felt like, oh my God, they bought this really expensive purse. I don't want it. I've rejected it. And when I thought about it, I thought, oh my goodness, this poor, people really kind of went out of their way to kind of give this gift, and she just anyway, I just thought that was a good example of
Right.
culture, and
And I believe that there could be a culturally sensitive way of not accepting the gift, actually. And you would talk about it differently, and you'd show that you understand the meaning of the gift and how big a sacrifice it was. And you would find a way to explain that, it's really important to me that, I receive a fee for your work, and I don't want you to have to pay me any additional money. In fact, we even have a rule in the clinic we're not allowed to. So I'm so touched by your gift, so meaningful, and it's beautiful, and I would enjoy it very much. But my values require me to not take it for these. I think there are ways that you could do that, but it requires a lot of cultural sensitivity and a lot of clinical skill. And these are not intuitive things that we know how to do naturally. It requires a lot of supervision and training to handle moments like this. Don't ask your patient for advice or confide your emotional difficulties to your patient. That's not what therapy is for. Now, maybe a mild exception. Let's say you have a patient who's a dentist, for example, and you'd like a recommendation for a really good dentist. You're not going to come to them for your dentistry, but I don't know if I consider that to really. I don't think that's like an exploitation. I wouldn't spend any time during a session talking about that because that's their time. But if you would say like, I need a new dentist, my dentist retired. Anyone you recommend that's really good, and I don't know that that's such a problem. Maybe other people disagree. Don't socialize.
I have a question to the advice part.
Yes.
How is it to ask feedback from a client?
Well, I think it depends if you're asking feedback because you're trying to assess what their experience is like in therapy, and that's part of the therapy. That's I wouldn't even, that's feedback. It's really more like sharing how it's going for them. What is therapy like for you? You're finding out information about their experience with you and whether they find it helpful, what they find helpful, what they don't. And you're using that information to, make the therapy move along, deepen the therapy, learn about what their experience is like. But if you need feedback because you're feeling insecure about your professional skills, I'm not saying that that's what you were saying, Menachem, but if you're asking feedback because you want reassurance and you want to sort of use them as like a, like a professional rating scale then I think it is a problem for the boundaries because they're becoming like your evaluator rather than your patient. So it's really, again, like the fundamental rule is, does it change their role or does it change your role with them? That's kind of the fundamental rule to think about. Be aware of, let me just finish. I want to finish this slide and then I'll take some questions. So don't socialize out of, that shouldn't say office hours. It should say don't socialize out of your office or out of the appointment. Like you don't have social time with your client outside of their appointments with you. Be aware of excessive texting and phone calls. Be aware of that. We talked about this last week also. Physical touch or hugs. I think it's really, even if you're in a culture where there's a lot of physical touch and hugs, and actually, I think South American and Latino culture, there is a lot more physical touch. A lot of people hug and kiss when they see one another. I think it would be good to not do that in your therapy office, even if you're seeing another member of that culture. I think it's good to not have affectionate touch as part of the therapy. A lot of therapy is to learn how to put your emotional affection or feelings in words and not in behavior and action. So all these things, handshakes, gifts, physical touch, hugs, they are enactments of physical affection. And I think that the talk that goes on in therapy is much more intimate and vulnerable than other relationships. So if it's combined with physical touch, I think that can be confusing or problematic. So I think it's good to really, there should be less physical touch in therapy than your other relationships, even though it's a culturally driven thing. Don't hire your patient as your accountant or podiatrist. We talked about that a little bit earlier. The principle, so that's rules-based. The principle-based way of thinking about boundaries is actually simpler. The rules are just applications of this. Be your client's therapist, carefully avoiding being anything else for your client. Don't be their matchmaker. Don't be their moneylender. Don't be their, don't make them your confidant. Don't, all the things. They're not your friend. You're not friends with your patient. So to really avoid doing anything other than being their therapist, because you'll see that it makes your professional role less secure. It forces you into situations where you're going to be unprofessional or act unprofessionally.
Would you say this is, I have a question. Would you say this is maybe slightly not as rigid for like a prescriber?
I think it is not as rigid for a prescriber. I think that's true. I think that it is not as rigid for doctors and people that are only prescribers and they're not doing therapy. I think that it is not as rigid for a prescriber. But I would tell you that just like therapists are, often not attuned to how vulnerable their clients are, I think prescribers, even though your client is not vulnerable in the same way that they would be if you were also their therapist, you're not aware of how vulnerable they are to you either. And, you talk about things with clients, you talk about their sexuality, about their self-esteem, about their feelings, about their emotions, about their relationships, about, you learn things that they don't want anyone else to know, and they confide those in you. And there's still, you have become a confidant. They put a lot of trust in you. So I think that they are more vulnerable to you than you're aware. And also because you're not doing therapy, you might not even be thinking about it. So you might be kind of more unaware than therapists are. So I do think that you need a heightened, vigilance about not entering a dual relationship where they might be exploited. Like if you would hire your client that you prescribe for to redo your kitchen and you're paying them for it, I don't think they're going to be able to negotiate with you as effectively as they can with somebody else. I do think that it would be probably problematic. I think Josh wanted to ask something before.
I just want to mention something that happened last night that created sort of like a deep internal sense of conflict in a way. I have a client I've been seeing for a number of years. We have like a very warm bond, and he's like very depressed. He has no money. We were speaking about different things that he could do, sort of like today, just to sort of get out of the house and be productive. And mentioned maybe walking to 7-Eleven to get a coffee, just something that he can do to sort of get himself moving a little bit. He said, I don't even have money for a coffee. So I knew that I should not have done it because I knew that it was like a boundary crossing, and I've never done it before, but I offered to not lend him, like to give him $20 so he has some money for coffee.
That's a
But
nice
on one
coffee.
hand, that's obviously a boundary crossing. On the other hand, it feels like sometimes you like want to be like a human being, a human being where you have someone who's like suffering in front of you and you want to sort of like act in a sort of a human gesture. And I've not had huge issues with boundaries in general, but sometimes it sort of feels like you want to say something, be there, do something for this person you care about, and at the same time you're like pulling yourself back into that boundary. So that's not a question. It's more like a reflection of sometimes how complicated these things can be.
Well, I think it's complicated because of the emotions that he pulls in you. We're not going to go into the case in detail here, and it's something, to discuss in supervision. But I would be suspicious or curious about the degree to which this is actually a countertransference to the way that he gets people to make sacrifices for him or do things for him or overfunction for him. I don't believe that you're the first person that has been kind of pressured to do something for him that they normally wouldn't want to do for someone. I think that he has ways, again, I don't know him, but this is just my experience as a supervisor. If you don't do this for lots of people, I don't think it's just because he's poor. I'm sure you've seen other people that have financial pressure, but he finds a way of telling you, I don't know what to do. I don't know how to get out and do things. So you give him advice is, no, that won't work for me. See, you're so insensitive to my needs and I can't do this. And everything you're doing is like not enough for me. I think he has a way of making people feel they're not doing enough for him. And then this is how people respond. So you're one example. So this is what we call an enactment. I don't think that this like sabotages the therapy and you can't move forward. But, how many times will there be advice that he can't afford? And gee, you helped me out last time. You're not helping me this time. Or when he doesn't pay you back, how long will that go on for? So I do think that it's an enactment. And what we do is, we analyze enactments as an opportunity to understand something happening in the therapy that's very deep. But I don't agree with saying it was human. I mean, a lot of stuff we do is human. It doesn't mean that it's effective or wise, because humans do a lot of things that are unwise also. So this doesn't sound like some damage was committed or something, but I do think that you look at your behavior as, actually, I think it might be the next slide, I talk about it. And when you deviate from your normal way of doing things, that's a signal, wow, something is really going on in the relationship. It's pushing me off kilter. That's how we use boundaries as a clinical skill. So that would be the task, is that he's pressuring me. He probably doesn't even know he's pressuring me. He thinks he's just expressing himself and being open and being vulnerable. But really what he's doing is he's pressuring you to do more for him than you normally would do. And it's hard to say no to him. There are patients that sort of demand being hugged, and it's hard to not hug them. So it's not so important whether you do or don't hug them. It's more important that you can use that information to sort of like figure out what's going on and get back on course. And in the moment, like, it's very easy in a seminar when you're not the person's therapist to think about what are the ideal responses, but that's not in real life how it works. Like in my office, I'm operating by the seat of my pants in real time, and I don't have the luxury of getting a consultation or talking to a group and then coming back and deciding what the right thing to do is. I'm reacting in real time before I even notice what's going on. So you notice that you were thrown off of your normal way of operating, and then you use that information to figure out what's going on. So I think that he is probably a sadomasochistic man who uses his victimhood as sort of aggression to make people do stuff for him. That's what I suspect. I doubt he's really so soft and harmless inside. I think he's powerful, and he does it in a way that's very hidden, because it feels like he's so aggrieved and disadvantaged. And there is a writer, his name is Searles, Searles. I believe it's Harold Searles. And he's written some papers about how just aggressive and vicious patients who look harmless are actually, how vicious and powerful they really are, how aggressive they are in a very hidden way. So that's my hunch, is that he might be someone in that category, but that's something to, think about with your supervisor. And then we all need therapy because of moments like that really, like, it's really hard to say no to a person that's made themselves vulnerable to us, and they're asking us for some kind of help or relief or affection or reassurance in the moment. It's very hard to say no to. And so we need a lot of therapy to know what our buttons are that get pushed. We all have buttons that all get pushed. That's why we need lots and lots of therapy. So I think moments like that are also for therapy, not only for supervision.
Nachum, can I just add just one little piece?
Okay.
I think we're giving a lot of attention to how much clients tend to sort of project onto us and imagine about us, but some clients are also very, very attuned to what our vulnerabilities are.
Yes.
And they will utilize that, maybe unconsciously, but they really will feel into where we are also very vulnerable.
Yes. There's I'm trying to remember who it was, but it was someone that was, when I was in residency, he was giving a talk on borderline personalities. And he said he would like to revise the DSM and add another criterion. There are 9 core criteria for borderline personality. If you have 5 out of 9 of them, you can get the diagnosis according to the DSM. And he said he wants to add another one, which is a radar.
Absolutely.
Radar for the vulnerability of the therapist. They just are so, so I don't know if this man is borderline or not, but somebody can learn much more quickly than the rest of us mortals can, that what is it hard for Josh to say no to, or what really pushes Josh's, buttons in a deep level, and with all the rest of us also, what it is. They size us up so immediately. I mean, it's really remarkable. And I think you're right. Now, it feels scary or aggressive or intrusive, but what it really is it's a survival skill. These are patients that grew up in really adverse, maybe abusive environments, and learning how to read people really adeptly was a survival skill that they learned probably when they were infants or toddlers, certainly when they were, children and adolescents as well. So they carry that with them because they needed to do that to survive. So that's what they're doing with us. So I think it's a really helpful example, Josh, and I am honored that you felt free to share that with us. So I want to go now
he said no to the money.
Oh, he said no to the money.
He said absolutely not. I would never do that. It was
Okay.
more me needing to do it than him wanting to receive it, which is more instructive in a way. But anyway, thank you. Thanks for taking so much time with it.
Or maybe he tested you, to see whether you would. I don't know.
He wanted a better offer, maybe.
Yeah. But I was going to say, $20 is a very nice coffee. I tried to say that before. That's quite a coffee. So, all right. So talking about the frame, and we talked about this a little bit last week, but to review, your frame is your actual routine of behavior in space and time with patients, and it supports your professional boundaries. That's what your frame is. How you do all the things you do as a therapist. And the metaphor, again, was national borders versus man-made structures, geography, and border security. The national border is something that was like agreed upon by the League of Nations or after World War I or the United Nations later. It's like the dotted line that's on a map. That's not real. That's a legal fiction that the international community has adopted. It's not a real thing. It might be that the border is, the Rio Grande River. So that's an actual structure in geography that we're using to demarcate the border. And then, when people say, well, we need to build a wall on a border, the wall is a man-made structure that's enforcing the border. Having border security there, having the customs office that you have to for a checkpoint. Those are all things that support the border. The border is boundaries. The structure is your frame. You construct a frame in your routine that helps you secure your boundaries. So, and again, some nations need more enforcement at the border than others. What's the metaphor for that? Some patients need a more rigid frame than others because they really challenge the boundaries. I'm sure we've all had patients that just try to chip away at like learning things about you. They want to learn more and more. They want to get information on you. They want to, why? I don't know. They may want to be in a less vulnerable position. They may want to show that they have power over you. They can't tolerate the fact that there's things about you that they don't know. Whatever the reasons are, there are people that chip away at things and they try to be your friend, try to know you, they want to relate to you in ways that are not professional. I think that those patients, you will find yourself kind of like enforcing your frame more rigidly than you normally will. Patients that are very late all the time, and then they expect to be able to stay late to make up for the visit that they were late for. At a certain point, you'll be like, wow, this is really like a recurring problem. I need to never be late for this patient, and I need to always stop on time. And, if someone comes 20 minutes late, say, look, we still have, if you have a 60-minute session, we have 40 minutes left because you're 20 minutes late, but I have a hard stop at 15 minutes before the hour, and I cannot extend the time. And then you will, when there's 2 or 3 minutes left and they're getting all wound up and starting to get tearful about something, you might say, this is very sensitive information, but it's coming out now when we have to stop in 2 minutes. So I want to remind you, you have to start to get yourself ready to leave in 2 minutes. That might sound cold or insensitive, but you do have to stop in 15 minutes. And actually, the frame and the boundaries are part of the therapy. So it may be therapeutically that reminder that they have to stop is maybe more meaningful and more important than the material that they're going to be talking about while they're tearful. And that's something that you'll find yourself doing in patients that are challenging the boundaries more than in patients who are not. Patients who have really good boundaries, you don't worry about this stuff because it's very clear. Patients that they don't understand the professional role. They're really in earnest trying to become your friend or your colleague or get referrals from you or give referrals to you, or they're really trying to do that and have a different relationship than therapy patient, you will find yourself becoming more rigid with the boundaries. And that's actually appropriate. But it's good to notice that you're doing it, because you say, why am I doing that? I'm not usually so, stern with the time. It's because this patient is challenging the relationship in so many different ways. That's why I think I'm reacting this way. And then you might be able to use that information therapeutically and talk about, what they're trying to do. Do they understand this? It's usually unconscious on the patient's part. Examples of professional frame. Well, I gave some examples. How you start, how you end, how you charge, how you get money, how you communicate. Do you communicate between sessions? What you text. I think the normal frame nowadays would be, texting is for logistical issues. You need to cancel. You want to know if I can change a time. You want me to remind you when your appointment is. And I'll do my best to get back to you in a timely manner, but I'm not looking at my phone all day long. I'm busy. So I can't guarantee I'm going to text you back immediately. Then you might have a client that sends you a funny meme. You might send a funny meme back. I don't think that's so unusual or necessarily a problem. But in the context of a patient who's confused about the boundaries or challenging them, you'll find yourself wanting to buckle down more on the boundaries. Deviation from the frame, that's a helpful sign for therapists to notice. When Josh, you gave an example of a deviation from your frame. That's something for you to notice and think about in the therapy. That's how we use this as a clinical tool. Boundary crossings versus boundary violations. So a boundary crossing is benign, natural, human, normal behavior. Benign means it's not harmful. Someone is not being exploited. It's emotionally meaningful. It's common, but it's self-contained. It doesn't turn into a whole new phase of the relationship, and it does not hinder therapy. Boundary crossings happen all the time. An easy example I can use is, and if I've said it to you guys before, I'm sorry, I don't remember, but I use it a lot in teaching. I had a patient who was really kind of housebound and phobic of leaving his home, and he was unemployed for like a decade. And about 4 years of his therapy was devoted to trying to get him to think about working again, make a resume, apply for jobs. It was just grueling and so painful for him because he was so ashamed of his gap in his professional record. And he finally did get a really good job. He's someone that had enormous professional skills, but had stopped working for a decade because of mental health concerns. And when he finally got the job, he came in and he showed me the offer letter, and I gave him a high five. So I really stepped out of my normal way of operating. I touched him with a high five. I was kind of like a big brother or a friend at that moment. I believe that was benign. That was my natural, spontaneous response. I was happy for him. I was happy for me. We were kind of celebrating this together. I was not acting as professionally in that moment as I always do. I did step out of my professional role. It was not a boundary violation. It was a boundary crossing. And those are normal things that we do all the time. We monitor them. We don't feel guilty about them. We monitor them and we consider what they mean. We talk about them in supervision. We talk about them in our therapy, but we're monitoring them. We don't worry about them. We monitor them. A boundary. So examples, someone sneezes, you say Gesundheit. Someone has had a loss, you give them some sort of condolence gesture or statement. You laugh, you share a joke, you share a meme. These are all kind of normal boundary crossings that happen in good therapy all the time. Boundary violations are very different. A boundary violation is harmful. It goes on indefinitely. There's no effort by the therapist to self-contain this, and the therapy is destroyed. Those therapies cannot be recovered. They have to be ended. I did not even bother to spell out in the rules-based section, so I'll say it now. According to every discipline, it is for many decades now considered unethical to ever engage in any romantic or sexual relationship or behavior with a client, and most disciplines, a former client, not just a current client, but a former client. And in some jurisdictions, including Israel, actually, I'm not sure about all the states in the US, it's actually illegal and it's considered criminal activity and it's punishable as a crime. So that is always, now that was not always true. There are well-known stories of famous clinicians who married their patients. Some of those patients are famous clinicians also. These stories are like over 100 years ago, or 80, 90 years ago. And these, it was not yet considered unethical by the field because the field did not understand the power of dual relationships or the power of the transference. And they felt that, you know, if romantic feelings are developing, you can end therapy and then pursue a romantic relationship. That was what the ethics were of the field. Ethics evolve over time. Ethics are not universal and timeless. Ethics adapt. So the ethics have changed, and it is never permitted, and it would always be considered a boundary violation. And it's really harmful for clients. Any questions here about the idea of the frame and
I'm just
boundary
wondering
process,
if,
boundary violations?
yeah, I'm just wondering if you ever notice if you're treating, a therapist patient or a very high functioning patient that you tend to soften the frame more.
I think that I soften the frame with therapists because now I'm not saying that I should, and I could present my work to a supervisor and be very open to feedback about, like, this is interfering with the work or compromising the work in some way. But I feel that most therapists understand the professional role, so I feel like it's more intuitive to them. So I'm not as worried about them misunderstanding the professional role. And I would say that the frame is softer with it's high functioning, but it's not high functioning like they're high functioning in their lives or their career. It's that they have really good boundaries. That's people that have really good boundaries. I'm less rigid about the frame, not deliberately, but I just won't worry about the frame in the same way. And because the nature of my practice, I really have a very wide range. I mean, I have some patients in my practice that are among the most sophisticated, high functioning, well-boundaried, wonderful people that I've ever met in my life. And I have other people in my practice who are really primitive, severe mental illness, lots of trauma with really adverse effects on their personalities and their ways of relating. And they are very reactive and impulsive in relationships because they're constantly trying to cope with, emotions that they can't handle. So I have such a wide range in my practice. And then because I teach this stuff, it's probably on my mind more explicitly than it would be if I weren't teaching this stuff all the time and supervising. But yes, I think that if you would put a video camera in my office, which I'm not going to let any of you ever do, and record all my interactions over a week, you would see big differences from one client to the other. I think you're right about that. Yes.
I don't see women in my practice, so this is just a theoretical question, but what would you do as a supervisor, or what should a therapist do that notices that they have some feeling of a romantic pull or connection with a client? Is that just sort of be worked through and sort of see where that leads, and then at a certain point maybe walk away from that? Like, I'm sure this has happened thousands of times.
Well, we're going to talk about that when in the lectures on transference and countertransference very directly. But I think that's the place to go into this. And I think if I go into it now, I won't do it justice because it's a very delicate topic that requires a lot of nuance and sophistication. I can't answer quickly. And it might also make it hard to go on to the rest of the lecture, but we're going to talk about that later in the series. very directly about erotic and eroticized transference and erotic countertransferences. We're going to talk about that. Someone else saying something?
I'd like to share, I guess. It's not really a question. I guess I'm just noticing that, like, as a newer clinician, I've noticed that I have a particular patient that he pushes on the frame, I guess, a lot. I don't think he means to do it on purpose. I think he's just so unaware of what's
He's not,
appropriate.
it's purposeful, but it's not conscious.
Oh,
But it is
right, yes.
purposeful.
No, it's purposeful to push, right.
Yes.
And I've noticed, like, I've been treating him for over a year at this point, and over the past probably like 5 to 6 months, my frame has become so much more strong and boundaried and rigid as I'm learning, like, how to understand
Manage
and
this.
interpret and navigate it. So it's interesting for me to hear it, this way also.
All right. Well, I'm happy to hear that that's the impact of your more recent professional supervision.
Thank you.
So, all right. So we'll go on to the next slide. Professionalism and fiduciary duty. This is an ethics perspective now. The purpose of professionalism is to protect the patient from exploitation. That's the purpose of boundaries from an ethical point of view. The clinical perspective is different than the ethical perspective. Like again, the ethical perspective, all those rules are there to prevent the client from being exploited. The clinical perspective is different. The clinical perspective is it allows the therapist to function at the best of his or her abilities. I don't know why I have an exclamation point there. You guys can interpret that. But so your frame and your boundaries make you a better therapist. Now, yes, of course, we also care about preventing your patients from being exploited. But I think if we only think about the ethical perspective, we lose our sense of what the boundaries really do for you as a therapist. You are a much better therapist when you are well boundaried and the boundaries are really intact. We are kinder, more patient, more thoughtful, more sensitive to our patients than our children, that should say, which is, this is a sad thing that I've come to peace with many years ago. I'm like a better therapist than I am a father. I wish that weren't true, but why is that true? Now, Erwin Hoffman comments on this. He says, psychotherapy treatment and often the patient actually do nourish some of the analyst's more ideal qualities as a person. This is a beautiful paper that Erwin Hoffman wrote.
Can you share it with us?
I did. There's the citation right there. That's the citation. So this is the boundaries put you in a perspective that you don't need anything from the patient. I need a lot more from my wife and my children than my patient. So if my patient disappoints me, it's just more grist for the mill therapeutically. Like, I don't need them personally to improve or do a good job or get an A on an exam or get into a professional program or, conduct themselves in a way that I would be proud of them. I don't need that from them. Now, if I have narcissistic needs as a therapist and I'm embarrassed of my patient behaving in public and I get mad at them because I'm narcissistically wounded, that's my personal narcissistic issue that I need to work on in my own personal psychotherapy. And we all have some of that with our clients. We all do have some of that with our clients. But in terms of reality, like, I need things from my wife. I count on my friends for things. So when they let me down, like, I'm mad in a way that I won't be with a client. It's very different with a client. So that's why the boundaries make you more patient, more tolerant. Like, you are more tolerant as a therapist than you can be as a father or mother. Now, I do also think that I have become a better person in my life because of my therapy skills. I think I'm more understanding. I think that I'm able to understand when people mistreat me. I'm able to understand, they're probably reacting to something and I need to understand what they're reacting to. I don't think that I knew how to do that in the same way as I did before I was a therapist, but nevertheless, that's like a downstream effect. I am better in the heat of the moment with a client than I am with a friend or with a relative or with a neighbor or with a business associate. I am better in that moment. It allows the therapist to stay safe, calm, reflective, and less reactive. That's what the boundaries do. The frame deviation, it helps you notice the pressures that the patient is unconsciously exerting. It allows you to see that. Projective identification and enactment. These are ways of understanding how the patient's behavior is unconsciously rattling you. They don't know that they're doing it. You don't know where it's coming from. You just notice, I'm getting so uncomfortable. I'm getting so aggravated. I'm so impatient. I'm so annoyed. And it could take many weeks or even months of that sometimes before you understand this is what the patient is doing to me. Now, it's interesting when you go for supervision with an experienced supervisor, they see it much faster than we do when we're presenting it for supervision because they're not in the middle of it. And that's normal. And that's what supervision is for. That's not a failure as a therapist. That's why we all need consultation or supervision our entire careers. That never really goes away. You're never going to stop being sensitive to projective identifications. They're always going to happen to you. And enactments. An enactment is really another way. That's just another perspective of the same idea. That's when you and the patient are kind of, your emotional issues are kind of coalescing at the same time and you're acting something out together at the same time. Because of your frame and your boundaries, you will notice this much more quickly, and you have like a whole routine, professional way of thinking about it that allows you to interpret it and get out of that enactment much more quickly. There's a popular misunderstanding I want to talk about, which is about boundaries versus limits. This is sort of like a maybe a millennial or Gen Z way of talking. Like, I have my boundaries. I need to set my boundaries. They're not talking really about boundaries. They're talking about limits. In other words, like, this is something that I don't want you to do. This is behavior that I'm not okay with. So like, if you're going to be friends with me, you can't talk to me that way. That's actually not boundaries. You're a friend. That's actually friendship behavior, is telling them you don't like when they do this. This hurt my feelings when you said this. You've done this now 5 times and I don't like it. And if you keep doing this, I'm going to have to change how I interact with you. That's really setting limits. So when you tell someone a specific behavior is not okay, that's limit setting. And we all have to set limits in our office. That's more related to the frame. But the boundary is what you're preserving. You're not, that's, the boundary is your role. You're in a professional role. If you don't want, like, I have a patient who, he likes to, like, even though he's an analytic patient, he gets up off the couch and kind of walks around my office. And sometimes he fidgets with my belongings. He's broken a couple things in my office. And I've said, like, you've lost privileges to touch my books. You're not allowed to touch my books anymore. Because, he broke a little picture that I have on my bookshelf. He knocked something else over. He spilled coffee. Said, you've lost coffee privileges in my office. And so, because he does this over and over again, so that's limit setting. That's not boundaries. That's limit setting. So limits are not the same thing as boundaries. Limits is like, you can't do this anymore in my office. Any questions here?
Yeah. So if the limit is the rule, I guess, that protects the boundary.
Well, it might just be that it's what you can't tolerate as a person. Like, you have to stop cursing at me. Like, I'm sick of you calling me names with 4-letter words in them.
Well,
That's just not allowed anymore.
That's the limit.
That would be a limit. Yeah, I'm not willing to.
What is the boundary in that context that's being protected?
That I am your therapist. I'm not your punching bag. I'm not a punching bag for you to vent at. Well, aren't I supposed to be honest? Well, I don't consider this honesty. I consider this lashing out. There's a way you could be honest without cursing at me and calling me names. And this is just unrestrained behavior. You can be honest, but still restrain your behavior. That would be like the limits. I had a patient who he picks his nails and pulls off his dead skin and just drops them on the floor. And I don't let him do that. Like, it's gross. Now, he is probably on the autistic spectrum also. But I don't think that I'm setting a boundary with him. I think I'm still in a professional role. I just don't want his dead skin and nails in my office. Just not allowed. He can't do that. If he starts to do it, I'll say, hey, Toby, stop doing that in my office. You're not allowed to do that in my office. So that's just something I don't want done in my office. I don't think that's a boundary. Maybe I guess if we think really deeply into it, maybe I'm saying, no, part of the boundaries are that, like, there are things that are acceptable and unacceptable that you have to comply with if you want to stay in a relationship with me. But I'm calling that limits more than, I don't think it's a boundary issue. It's just like, I'm not unprofessional or feeling like my professionalism is challenged in some way. I'm not feeling pulled off of and it's really, I'm not changing my frame. It's just no one's ever done that before in my office. And I never thought that I'd have to tell someone that they can't do this. Now, what do people do all the time? They cancel appointments. So before you even meet with me, I have a cancellation rule. I haven't had the need to develop a picking nails and dead skin rule in my office. It's so unusual. But even the cancellation policy, it's not really about boundaries. It's really about just protecting my professional time. It's a rule that serves my best interests and it allows me to stay open in practice. So those are limits more than boundaries, I would say. I think that we're getting toward the end, and I think these are the most important things. And I think that there might be something, we'll go through this pretty quickly. That, the professionalism and your fiduciary duty, back to this, you're providing a service that you're qualified for based on your training and experience. That's what you're hired to do. You're acting in your client's best interest. You're paid and hired with the understanding that your duty is to look out for your client's best interests. Certain professional roles built into what's expected is that you're hired to always be looking after your client's best interests. That's actually part of the role. Like, if you hire a painter to paint your house, he's not your fiduciary. He's just your painter. He's a professional, but he's not your fiduciary. A therapist is a fiduciary, like a lawyer or an accountant or your banker or your investment banker. Like, part of their job is to look out for your best interests. So therapists have that charge to always be looking after the person's best interest. That is an ethical thing that's built into the role. This is a term from the Talmud. It means apotropos. It actually means like an agent or a guardian or a custodian. And I'm just bringing it up because it's an ancient concept. There are people who are appointed to look after someone's best interests. This is not a new idea to therapy. It's like it's in sort of natural law. But therapists have this charge. This is a biblical verse which is about how judges need to conduct themselves. It says, "Do not show favoritism in a legal proceeding, and do not accept bribery, because bribery blinds the eyes of the wise and perverts the words of the righteous." And the commentators say it's a really interesting verse. It's wise people and righteous people that will be blinded or perverted or corrupted. Really, probably corrupted is a better translation than perverted. Wise, righteous people are corrupted by bribery. It's not that, like, I'm righteous enough that I could get a gift and it won't corrupt me in some way. So I once received a ruling from a rabbi who said that professionals who are expected to serve as fiduciaries, they have the same duties as a judge. Now, why am I bringing this up? As a therapist, you have to be really, really careful that patients are not bribing you in some way, or they're not inducing you to do things for them which are actually going to throw you off of your professional role. It's like a heightened kind of scrutiny you have to your role as a therapist. And what I wanted to talk about with that is gifts, actually. That gifts, when you receive gifts from patients, and another thing I want to bring up, then I'm going to stop here with the formal presentation. We're going to talk about, just have a discussion for the rest of the time. When you have, if you get a gift from a patient, I think you just won't be as good a therapist. A really valuable gift that's like financially helpful for you, you will not be as good a therapist as you would be otherwise. There are some therapists who work in communities where there are some really, really wealthy people, like they have billionaires as clients. They have other people who are really poor, and they develop like a sliding scale. And the way they think about it is that, well, my really wealthy patients kind of subsidize my ability to work with poorer patients. But I think that what I see happening is that if you have a really wealthy patient who could afford like, a really like exorbitantly expensive fee, and it's not a big deal for them, if you charge that patient more than your full fee, I think that you are actually going to be off of your professional game, and you're not going to be doing a good job, actually. That's what I really believe. I think that you will be kind of held hostage. And I have seen some therapists that just get huge amounts of money each year from like one client because they pay so much per visit, and they see them multiple times a week. And then they also see other people in the family, and they're seeing them in group therapy and individual therapy, or marital therapy and group therapy and individual therapy. I've seen this happen with a number of people, and that is a boundary problem. And the boundary problem is not just that they're in a dual role where they are both a marital therapist and an individual therapist. That's a straightforward boundary problem. But it's also just that this person is giving you so much money per visit, you're just not going to be as objective. You're not going to do as good work as a therapist. I really believe that that's the case. And I think that that is an issue. Our communities have a really diverse range of income. Like in the same neighborhood, you have billionaires and people that are like on Section 8 housing and food stamps. I know that sounds very odd, but like it's right on the same block. You have people that are billionaires and that are indigent, and they actually dress the same and look the same superficially. And they could both be in your practice. So if you end up having someone that's willing, and there's also another funny thing in our ethnic community. There's it's a peculiar idea that the more you charge, the better you are. And the validation of your skills is that you charge a huge fee. So there are clients that some of you have had, because I know your therapy cases, where they are uncomfortable with how low a charge you charge. They think you don't charge enough money. There must be something wrong with you. They've complained, like, he needs to charge more money. This is unacceptable. He doesn't charge enough money. But, this is another cultural idiosyncrasy to work with in our community. But I think personally for the therapist, if you're there are some clinicians that are charging now in New York, like $1,000 a visit. That's actually happening with some people. It's strange, and they're getting away with it because they have really, really wealthy clients. I think that they're not doing nearly as good work as they do with their other clients. I really believe that. So that's an interesting issue with boundaries. So what
Can I just say something?
We'll see.
If you were, a really gifted, I don't know, kitchen designer, I don't think I'd set my fee based on a person's income. This is what I charge. This is what a designer kitchen looks like. It might be $350,000 if you can't afford it. I also have $60,000 options. If I'm a really legitimate professional therapist and I abide by ethics, then my fee might be 200, 250, 300, whatever it is. If someone is truly indigent, I might offer them a sliding scale, but I certainly cannot up my fee because you're wealthy.
So kitchen designers are not fiduciaries. That's not part of what they're charged to do ethically. I don't know if kitchen designers have conferences. I've never been to one. If they do, I doubt they have a lot of ethics sessions. And they don't have like continuing education credits where they have to do ethics also. And I'm sure you have never worked as a kitchen designer, because I have no doubt that kitchen designers absolutely consider the financial position of their clients before they make a bid on a kitchen. I have no doubt that's the case with every kind of construction in a home. They absolutely are going to pick different kinds of products that have a much bigger profit margin. They're going to order things from designer dealers where there's a much wider profit margin for the designer themselves. I think that they absolutely do use the financial status of their client or socioeconomics of the client to decide on what they're doing. I don't think that there's like a one. Now, yes, if you go to Home Depot to buy appliances, it's a standard price for everybody. But a custom kitchen designer, they absolutely charge differently based on, the neighborhood it's in, the expense of the house, and what they think you're able to pay.
I guess I'm naive.
That's well,
Right, but she's
I want
talking
to bless.
about an hourly, but she's talking about like an hourly fee, meaning if a kitchen designer is charging $150 an hour for their design time,
They
right?
don't charge $150 an
No,
hour.
really not. I think I'm naive.
In
I think I'm just assuming that people are bound by a sense of ethical responsibility, and they'll say, "How much do you want to spend?" Not, "I'm going to suddenly order the highest end appliances because I'll make a better profit, and it will also serve my image as a really gifted, designer, and this is going to be a showstopper kitchen, and I
They
can do it because you can
absolutely,
pay for it."
they absolutely do that. They absolutely do that. And and as far as charging per hour, I doubt that people charge the same fees in Kew Garden Hills that they do in Englewood, New Jersey. I doubt they do. I think that it is absolutely different.
It,
You
it
know what, Dr.
definitely is.
Lynn?
If you go for therapy in Woodmere, you're looking at 300 minimum a session. There's no such thing as a rate under 300. That's as far as I'm aware.
That's
That's
okay.
the
So
rate.
we're driven by economics, but what I'm saying is that I think, if you have a fee that you charge and that's your full fee, that's fine. But if you charge more than your full fee, or your sliding scale is so wide in range that really wealthy people are paying you like huge amounts of money, that if you would get that 40 hours a week, you'd be making millions of dollars a year. I don't think that you are the same therapist for patients that pay you that much money. Like, think about how we all struggle with, wow, if I say this to the client, they might get really mad at me and they might leave practice. Or if someone is like 50% of your income or 30% of your income, you're going to be different with that client. You're not going to be as skillful. Like, it actually throws you off your game. I think that's the case. I'm not saying that this is something that all of you are struggling with in your practices, but I think that you do work in communities where there are therapists that do have this issue. And our communities have really poor people, lots of in-between people, and lots of really wealthy people. It's a really wide range. And they live on the same street in the same block. It's very interesting. I think
I'm
it's something
I'm so
that's,
curious what you think about not offering a sliding scale at all and saying this is my fee.
I have no problem if you don't offer sliding scale. I have no problem. I think that you make that
Simply not to
decision.
differentiate treatment in any way and not to be.
But I think that you offer a sliding scale if you want to treat certain people and they can't afford you. I'm a psychoanalyst. If I don't offer a sliding scale, I'm not going to have any psychoanalytic patients, or I'll only have massively wealthy psychoanalytic patients. I don't want to do that because I don't want that kind of practice. If I have that kind of practice, I think that I'll be very limited in my professional work. Also, if you've ever worked with people that are really in like the top 1/10 of 1%, it has its own challenges to work with that population. They cancel all the time. They
Yeah.
cancel lots and lots of appointments. They don't mind that you're and they sometimes don't even tell you in advance that they're canceling because, well, you're getting paid. Why should I have to cancel? And they have emergencies all the time because they are running important businesses with lots of people that depend on them. So they do have legitimate reasons they have to cancel sessions. They travel a lot. They make decisions to travel at the very last minute. They have multiple homes. They often don't know where they're going to be next month. I don't know if I'll be, in California, or I'll be in Spain, or I'll be home. They make decisions to travel at the last minute. They forget to tell you because they have so many people that they have to tell, and they honestly just forget to tell you. And it isn't narcissism or lack of considerateness. It's just the nature of their lives. And that's a hard population to work with. And a lot of them may not stay in treatment long term because their intermittent being in and out of therapy makes it hard for them to really develop deeply into the therapy. So I wouldn't want a practice of only, first of all, I'm not in a community that I could even support that. But in theory, I wouldn't want psychoanalytic patients that are all worth hundreds of millions or billions of dollars. I wouldn't be doing the kind of work I do. I wouldn't be developing as a therapist the way I do. And very few people could pay your full fee 4 times a week. You have to be really wealthy to do that. So I absolutely lower my fee for people that I see multiple times a week. I'm much less likely to ever lower my fee for supervision, because supervision, I'm helping someone generate income. And this is what I charge for my time. And this is not like I don't consider this like a financial hardship that you're getting supervision. I consider this to be a professional expense that you're doing to invest in your work. And I actually believe that if you're in supervision with someone that's helpful, your income should really go up. Your practice should very visibly get better, and your income, you should see the benefit for your income through supervision. I really believe that's the case. So I tell people, if you think this is not helping your practice, let me know, and we will decide whether there's a better consultant or supervisor for you. But I believe that you would see the impact. I believe it would very easily pay for itself. And I do believe that. So I don't lower my supervision fees. I do lower my clinical fees for people that come more than once a week. And I don't think I've had maybe one person who paid my full fee 4 times a week, but other patients lower their fees. I mean, it would just be too much money to charge. So I think that we do that. And I don't think that it's really accepting a huge amount of money. One other thing I want to say is that you have to be also very careful. I'm hearing a pattern among some young therapists, actually not even necessarily young, but they're early therapists in their careers, and they want to immediately move into only private practice because it's much more remunerative, and they don't want to see insurance clients, or if they see insurance clients, they feel like more taxed for their time and their efforts. Your practice is going to turn you into a better, more successful therapist. You should feel equally invested in your low fee cases and your insurance cases as you do in your private cases, because you're going to be getting really good professional experience and you're going to grow as a therapist. It is much worse for your practice to have less hours booked and get more per hour than to have more hours booked and have less per hour. I know that, like, from a purely financial thing, that sounds counterintuitive, but you really have to look at the experience you're getting with a wide variety of clients. That is making you a more skillful professional who's going to have a much more successful career and practice over many, many years. So you really have to look at, I see my analytic patients who pay much less money per visit, and it might be a very low fee they pay per visit. It adds up to a lot of money for them, but it's really going to be a hit on my income because it's multiple hours a week at a very low fee. But that does so much for me as a clinician. And that's how I'd encourage you to think about insurance work and people that are paying less money. I think that people that only want to immediately move to seeing only very wealthy clients that can pay for a lot per visit, or people that are paying private, they don't develop as well as therapists. I've seen it more and more. The people that are the most skillful therapists that have really long, great careers and have a lot to offer as therapists, they treat everybody they think they can help. It has to be within certain parameters so you can stay open for business. But, if you would see an insurance company pays $100 a visit or $75 a visit, it isn't no money. I mean, if you'd be full 40 hours a week with $75 a visit, that's $150,000 of income a year. That is income. And you'll have other people that pay more than that. So I think that people should try to be open to the fact that you have a great benefit in seeing people that also pay a lower fee. You can't ruin your whole income with, such low fees that you're not making enough money and you can't pay your bills. But I think that there is, unfortunately, a tendency now of some young therapists to expect to go right into private practice and charge lots of money, and it really isn't realistic. And it isn't actually good for you.
Mm.
Any other thoughts? So we're 5 minutes over. So I will say goodbye until next week.
Thank you.
Thank you so much.
So long.
Good Chavez.